Picture this. A healthy young woman walks into your clinic. You take a listen to her heart, and there it is, a murmur. But here's the trap. That murmur is lying to you. It's a scenario that catches almost every medical trainee at least once. So let's dive into this explainer and completely redefine how we think about cardiac auscultation. So you're listening, and you hear this distinct ejection systolic murmur right over the pulmonary area. Naturally, your brain jumps to the most obvious conclusion, right? You assume it's pulmonary stenosis. But here is the wild twist. The actual lesion, an atrial septal defect, or ASD, is literally a completely silent hole. The defect itself isn't making a single sound. And honestly, if you don't grasp that critical distinction, you risk misdiagnosing this lesion for your entire career. ASD is an absolute masterclass in why understanding the mechanics beats just memorizing clinical findings. Section 1. Anatomy of a fake murmur. All right, trace the shunted blood with me to see how this murmur is actually just a downstream consequence. In a normal heart, left atrial pressure is higher than right atrial pressure. So when there's a hole between them, blood shunts from left to right. But here is the absolutely crucial point. The pressure gradient between these two atria is actually incredibly small. And because of that low pressure, the flow directly across the hole is low velocity and non-turbulent. That is exactly why the hole itself produces absolutely no sound. Instead, the shunted blood enters the right atrium, crosses the tricuspid valve, fills up the right ventricle, and is finally ejected across the pulmonary valve. It's that massive increased volume of blood crossing a structurally normal pulmonary valve that generates the murmur. It's kind of like a relative or functional pulmonary stenosis, caused purely by volume overload. And while we're looking at the anatomy, it's super useful to contrast the ECG findings of the most common ASD types. It really helps you quickly differentiate them clinically. Ostium secundum, which is by far the most common type and is located near the fossa ovalis, typically shows right axis deviation on an ECG. On the flip side, ostium primum, which sits much lower in the septum, typically shows left axis deviation. It's just a simple electrical clue that directly reflects their different embryological origins and how they disrupt normal conduction pathways. Section 2. Decoupling S2 fixed splitting. Okay, understanding the mechanical physics of this next physical sign is going to make it completely unforgettable. Normally, your S2 heart sound splits just a bit during inspiration, because increased venous return to the right heart delays the closing of the pulmonary valve. Wide and reverse splitting are both entirely tied to respiration, but look at the bottom row here. Fixed splitting stands completely alone as a respiration-independent phenomenon, and it is the absolute hallmark of an atrial septal defect. So why does that happen? Well, because the right ventricle is already completely flooded by that constant left-to-right shunt. It is chronically volume overloaded. Because of that, its stroke volume and that delayed pulmonary valve closure remain totally unchanged whether the patient is breathing in or out. The right heart is already at maximum capacity, so taking a deep breath doesn't add any extra delay. The chronic overload has beautifully, yet pathologically, decoupled the valve closure from your respiratory cycle. Now, we definitely have to be careful not to confuse flow murmurs with actual structural disease. The crucial point here is that if you hear a mid-diastolic murmur at the mitral area rather than the tricuspid, you're dealing with genuine valvular pathology and not just a benign flow murmur from the shunt. We call this Luttenbacher syndrome. It's the specific combination of an ASD with actual mitral stenosis. Distinguishing this is absolutely vital because true valvular pathology demands its own completely separate management strategy. Section 3. The hidden threat, tolerated but not harmless. A lot of the time, patients remain completely asymptomatic for decades, which honestly makes this pathology a hidden trap just waiting to spring. Because the pressure gradient between the atria is so incredibly small, the right heart tolerates the extra volume remarkably well for a long, long time. But tolerated definitely does not mean harmless. Left uncorrected, the chronic volume overload drives a dangerous domino effect. Over the years, it progressively dilates the right atrium and ventricle, which stretches the tissue and substantially raises the risk of atrial fibrillation. Even worse, decades of excess blood flow slamming into the lungs causes progressive pulmonary vascular remodeling. Ultimately, this can result in end-stage isometriophysiology. That's where the shunt reverses, leading to severe irreversible pulmonary vascular disease, characterized by cyanosis and clubbing. And that brings us to one of the most underappreciated dangers of an ASD, the paradoxical embolism. Normally, a blood clot forming in the veins would travel to the right heart and get trapped in the lungs, causing a pulmonary embolism. But with an ASD, that clot can just slip right through the hole, bypassing the lungs entirely and shoot out into the arterial circulation. It heads straight for the brain, causing an unexpected, otherwise cryptogenic stroke in a seemingly healthy patient. It's a terrifying thought. Section 4. The Fix. 2025 ACC/AHA Closure Guidelines. The decision to actually close an ASD is heavily driven by the numbers, specifically the QP to QS ratio, which compares pulmonary blood flow to systemic blood flow. Current 2025 guidelines state that closure is generally recommended when the QP to QS shunt ratio is 1.5 or greater. This tells us the shunt is physiologically significant and actively altering the heart's hemodynamics. However, the size of the shunt is really only half the story. The resistance in the lungs is the other half. For a Class 1 recommendation to close the defect, this significant shunt must be paired with a pulmonary vascular resistance of less than 3 Wood units. This indicates that the pulmonary vasculature hasn't undergone permanent remodeling yet, which makes closure safe and highly beneficial, even in totally asymptomatic patients.
But what if we catch it a little late? Well, if the pulmonary vascular resistance sits in this intermediate gray zone of 3 to 5 Wood units, closure decisions require highly individualized expert care at specialized centers. In these borderline cases, teams might use a fenestrated device. That's essentially a patch with a small hole in it, acting as a safety pop-off valve, just in case the right heart struggles to adapt to the sudden change in flow.
And here is exactly where the window of opportunity closes. Once pulmonary vascular resistance becomes fixed and elevated above 5 Wood units, closure actually becomes strictly contraindicated. No way around it. Why? Because at this late stage, the overloaded right heart is relying on that hole as a necessary pressure relief mechanism. If you plug the hole now, the right heart will acutely fail against the high pressure of the lungs. When you do proceed with closure in suitable patients, the anatomical type entirely dictates your method. Percutaneous transcatheter device closure, using a wire guided up through the groin, has largely replaced open surgery as the preferred first-line treatment for the common secundum defects. However, open surgical closure is strictly required for primum and sinus venosus defects. Their specific anatomical locations simply aren't suited to securely hold a catheter-delivered device. Section 5. First Principles and Next Steps. Let's pull this whole picture together. So, the next time you encounter a pulmonary flow murmur and a fixed split S2, don't just name the finding and move on. Think about it. Trace it back to its source, one valve upstream, to a completely silent hole doing all the real hemodynamic work. Understanding the why behind the murmur, the fixed splitting, and the closure thresholds completely demystifies the pathology. If you found this breakdown of first principles helpful, please hit that like button, leave a comment with your questions, suggest new topics for us to cover, and make sure to subscribe so you never miss an explainer. I'll leave you with this. Knowing what you know now, will you ever hear murmur the same way again?